Again, this patient, remember, was a 69-year-old, retired, so, kind of on that borderline transplant candidate, but I guess a lot of people would do it. Hypertension, so minimally other comorbidities, comes with myeloma, with a pretty significant anemia. Go to the next slide. As you remember, so for this, let's go ahead and, what was the answers? Let's ask it one more time, and then I'm going to see what Michael and, so what would you do? Skeletal survey, bone marrow biopsy, cytogenetics, next-gen sequencing, all the above, answers 1 to 3, 1 to 2.
Nice.
All right, so 1 through 3. So, sorry for you, Joseph, what would
Yeah.
you do in this? Is that?
No, absolutely. I mean, I think right now, skeletal survey is still the standard. It probably will change at some point to to full body low dose CD or CT or other kind of modality. But considering this question, obviously they need a marrow, they need a cytogenetics. We're not really doing next gen sequencing on plasma cells up front. So I think 6 is the correct answer.
So, Bill, when are you doing next gen sequencing, or is there any reason to consider that?
I'm doing it because it's a research tool. It's a way for us to evaluate MRD. And so we can do next generation sequencing. We can determine what these clonal abnormalities are and use that as a way to measure MRD in our patients who achieve great responses. And I'm hoping it's going to guide me on therapy. I have a patient, for example, who has very high risk features. She's plus 1Q, 17P, treated her with a Kyprolis-based induction transplant. She's in a CR, but by MRD, she has disease that's detectable. She has about 100 sequences per million cells that are detectable in her marrow. I offered her an allo transplant, but she's nervous about the side effects and the mortality. So we're treating her actually with a daratumumab-based maintenance, and I'm actually going to use this to follow her to see if we can eliminate these clones. In about 6 months of therapy, we'll do another marrow and look again. So I think it could be very useful for managing some of these patients.
So let's go to the next one, or actually let's go to the next one. Let's just do, and I just want to kind of bring this one up for the panel. Go to the next slide. Oh no, we don't need to ask it. Let's just go to the next slide. And actually just show the responses here. We don't need to re-question this, but I would like to hear from Bill. You start with, what would you have chosen in this patient as first-line therapy?
So first of all, this is a transplant patient, and so as Joseph has pointed out, transplant still has important value even in the era of novel drugs. So I'll use a triplet for induction. For non-protocol patients, and obviously I have a bias toward research protocols, but for non-protocol patients, and if I can get approval, I will use carfilzomib, lenalidomide, dex for induction because I think it's better. I think it's superior to VRD.
And I didn't put it on there, but would they all get maintenance post-transplant?
Virtually all of my patients get maintenance.
Yeah. So
Yeah, I agree.
anything?
I think you're right. Again, I think the evidence, need a little bit more evidence for superiority of KRD versus VRD, but as you saw in our MSMART guidelines, we do recommend, especially in the high risk patients. So in a sense, I'd look at question 1 and answer 1 and 6 as being correct in the sense that someone would give VRD, but then I would take them to transplant. The only issue in that patient, remember, their creatinine was 2.3, but that was initial. It quite likely will drop with hydration and treatment and so on. That's not a contraindication, by the way, to using lenalidomide. We've just finished our study. It was in relapse disease, but we looked at lenalidomide in patients who had true renal insufficiency. The bottom line is you can pretty well use full dose in just about anybody, even on dialysis. We tend to dose reduce a little bit on dialysis, but the phase 1 study, we didn't really have a lot of negative outcomes from it. So don't be afraid of using lenalidomide in your renally insufficient patient. Even if you use a lower dose, I would still give it.
So with that, let's see, what I told you get done on time. I got at 1:47. I said we're going to adjourn at 1:50. So I got 3 minutes to talk to you here. So if you guys don't really want to listen to me for 3 minutes, let me just thank all of our speakers and Dr. DeVos for a great job.